welcome to the EMSNation podcast. I'm your host, Faizan Arshad. Today, we start right where we left off, discussing part 2 of the historic New York State collaborative protocols, the nuances, the evidence, the rationale for implementing and instituting this new set of protocols across 13 out of the 16 regions in New York State. So, if you have not listened to the first episode in this series, I behoove you, take a time out, pull your car over to the side of the road, download that episode, and listen to it first. There's a lot of goodness, fantastic discussion, and I am excited that Dr. Chris Fullagar from Syracuse, New York, joins us once again to round out our discussion on the collaborative protocol rollout with this second podcast. Welcome to the show, Chris.
Well, thank you again, Faizan. I am thrilled to be here, and I am so stoked about these protocols.
Fantastic. So I think the people love the first one, so we should begin right where we left off. And that is for the agitated patient and excited delirium. This is a problem that's not isolated to New York State. Excited delirium indeed exists all across the planet, and it's challenging and endangers providers. And, really until this point, we have not had an effective handle on sedating patients that we could not talk down via other de-escalation attempts, strategies, and ideas.
Absolutely. One of the things that I wanted to touch in regard to this is the difference between the agitated patient protocol and the excited delirium protocol. When we're discussing the agitated patient, now the difference between the two can be a little nebulous, especially if you're new to this. But when we discuss the agitated patient, what we're talking about is a patient who requires sedation, for whom we really aren't able to de-escalate the situation using interpersonal communication skills, and for whom we need to give pharmacologic management. But the patient is not in an instance in which they are at immediate risk of causing physical harm to emergency responders, the public, and or themselves. And I think that's the main difference that we are intending to convey between the agitated patient and the patient who is suffering true excited delirium.
I think that's an excellent point. There's certainly a continuum of care, and providers need to be trained effectively on when to sedate a patient and how to effectively employ de-escalation strategies. We mentioned in the first podcast the multitude of uses of ketamine as an NMDA receptor antagonist, and our discussion primarily was the use of ketamine to support our hemodynamics during RSI. So along those lines, ketamine can also be used for excited delirium now in New York State via standing order.
Absolutely. And when we're dealing with excited delirium and patients who are suffering from excited delirium, these are patients who require immediate intervention or else harm is likely to occur. And ketamine is one medication that is fairly reliable in the effects that it will have on the patient at a particular dose, as opposed to benzodiazepines such as midazolam, which also can be used on standing order in this case. Midazolam may have a very different effect on different patients. With smaller doses of midazolam, some patients may become essentially apneic, whereas other patients will really not have much of a response at all to much higher doses of midazolam. And it can be very difficult to predict ahead of time how the patient is going to respond to the various doses of midazolam. So ketamine, in this case, has a much more reliable effect and a predictable effect, with the therapeutic response occurring within just a few minutes of intramuscular administration.
I think it's a great point, Chris. And we recall that in this setting for excited delirium, the medications we're administering for chemical sedation are via the intramuscular route. So one of the fears of using ketamine is the potential for laryngospasm. Now, number one, that has to deal with the rate of administration, and two, that's primarily in the IV route of administration. Now, there have been several larger scale pre-hospital studies using ketamine in excited and super excited delirium, and one of the boons of this agent or drug is that the airway reflexes are left intact. So while the patient is sedated and can then be transported safely, it does not affect the airway reflexes.
When we're dealing with the agitated patient, on the other hand, we may have the ability to titrate the medication where we don't need an immediate effect to avoid disaster. This is a patient who is significantly agitated and refractory to verbal de-escalation techniques, but requires some degree of pharmacologic management. Now, as we mentioned in regard to the benzodiazepines in this case, the patient may respond differently than other patients that you may have administered a similar dose to. So especially in the elderly or other high-risk populations, you may want to start low, and this protocol allows you to do that. For the critical care and the paramedic levels, on standing order, the provider may administer midazolam up to 2.5 milligrams IV or up to 5 milligrams IM per dose. Now, the up to allows the provider to use their judgment and titrate based upon the potential risk as well as the need for rapid effect. Now, under standing order as well, you may repeat this up to 10 milligrams. So that means that if you decide to give 2 milligrams IV, you can do this a total of 5 times as needed.
Great point. And I think there's certainly nuance to the use of these medications. Now, something else that we don't commonly consider a medication, but certainly should start to think about it this way, is oxygen. And I know that'll sound strange to a lot of providers, but oxygen should be thought of as a medication.
Traditionally, EMS has been instructed, and physicians, the whole gamut of medical care, really, to provide oxygen to essentially every patient who is sick. And the thought is that oxygen couldn't hurt and it might help them. Unfortunately, what we've learned is that there are very real risks of administering oxygen, just like any other medication. And if we think of oxygen as a medication and provide it only to people who need it, we find as though we are administering it more appropriately and decreasing the risk of unnecessary oxygen administration to patients.
I think that point is very important. In fact, there was a recent study looking at patients who had ST elevation MI and looking at the use of oxygen in those patients. In fact, they found that for patients who were not hypoxic, had an adequate SpO2, the routine use of oxygen, in fact, resulted in an increased mortality. In addition, several ICU studies have also come out in regards to the toxic effect of hyperoxia. And we have to remember that oxygen, especially in high concentrations, promotes free radicals as well as oxidative stress to the body, as well as all the organs. So it is not a benign drug. It should only be used judiciously and in those patients that exhibit hypoxia.
And along those lines, to attain that, in the past, we have instructed the providers that anyone who requires oxygen is to receive the oxygen via a non-rebreather mask of 15 liters per minute. In the new protocols under airway management and oxygen delivery, we've changed that at the EMT level and above for the participating regions to allow the providers to select the appropriate oxygen delivery device for those who require oxygen. And the goal is to maintain oxygen saturation of greater than or equal to 92%. If you have a patient who is greater than or equal to 92% on room air, they really don't necessarily need any supplemental oxygen at that point. But if they are below that, you may go ahead and administer the oxygen via a non-rebreather mask at 10 to 15 liters per minute or a nasal cannula at 2 to 6 liters per minute, whichever is the most appropriate for that patient.
Great points, and I like that we have the ability to choose the appropriate oxygen delivery method. Since we are talking so much about oxygen, what about during RSI?
So this is a little bit of a change for people who have been instructed on the use of a nasal cannula. All throughout, as far back as I can remember, we were always told never to administer oxygen via nasal cannula above 6 liters per minute. And in general, that is still the case, with one exception. And that exception is during rapid sequence intubation, or RSI. In these cases, we found that passive oxygenation while the patient is undergoing RSI is best achieved with a nasal cannula at 15 liters per minute. Now, this is important to remember that this is only during the RSI procedure during the intubation attempt. So the patient is sedated and the patient is paralyzed, and we will administer oxygen the way that we normally do via the bag valve mask, but in addition to that, we can connect a second oxygen tank to a nasal cannula to also deliver 15 liters per minute to provide passive oxygenation to decrease the risk of hypoxia, which we know that even a single episode of hypoxia has been shown to increase mortality in patients undergoing this procedure.
I sincerely appreciate your point, Chris, but in trying to teach this concept, there are a lot of skeptics out there. Won't I cause a pneumothorax if I increase my oxygen flow rate via the nasal cannula to 15 liters per minute? Can't I potentially cause barotrauma?
No. And the reason for that is that we are providing a passive oxygenation. We are not providing active positive pressure ventilation into the lungs. The reason why we typically don't go above 6 liters per minute via nasal cannula is because it's fairly uncomfortable for the patient. And over a longer period of time, it may cause some harm or drying out of the nasal mucosa. In this particular case for RSI, it's for a very specific indication for a short duration in a patient who is sedated during the entire procedure. So it's important to know that while it's true we normally should not administer more than 6 liters per minute via a nasal cannula in the field, in this particular case, it is actually potentially very beneficial to the patient.
I think that's very insightful. And it may help providers to know that in the hospital, via the use of a high-flow nasal cannula, that we can often administer flow rates of 40, 50, or even 60 liters per minute via a type of nasal cannula. And we have to remember that the nose, and particularly the turbinates, are designed to encounter these types of flow rates, and it is completely safe in patients and will not cause barotrauma, especially during RSI. And this concept is apneic oxygenation.
Absolutely. Thank you.
Next up, we have protocol 2-6, allergic reaction.
The main reason that I wanted to bring this particular protocol up was the difference in the indications for administering epinephrine, and that is delineated in the EMT level. The only time that we would really administer epinephrine to a patient who is having true anaphylaxis is if they are having significant respiratory distress and or hypotension. We do not want to administer epinephrine for an allergic reaction without anaphylaxis because, like any other drug, there are significant idiosyncratic effects of the epinephrine if it is given to a patient who doesn't need it. So when we are selecting for patients who are either having or at risk for anaphylaxis, if a patient has exposure to a known allergen and is developing respiratory distress and or hypotension, that is an indicator to administer the epinephrine. You really do not want to administer epinephrine to other patients who are having an allergic reaction or having other signs or symptoms of allergic reaction, with one particular exception. And that exception is the patient that has a history of true anaphylaxis. And these are people who have had an exposure to a particular allergen and have been exposed again to that allergen in this instance, who are developing respiratory distress and or hypertension. But the other thing is if they have a rash. So normally if a patient just has a rash after an exposure to an allergen, that is not an indication for administration of epinephrine unless they have had a previous history of a true anaphylactic reaction.
Excellent point. And since we are talking about epinephrine and we are in New York State, we should briefly highlight the Check and Inject program, which was loosely modeled off of Washington State.
Yes, the Check and Inject program is an excellent program which has been approved for mainstream use by the BLS level, in which EMT basics can administer epinephrine using specialized syringes where they would draw up the medications to a predetermined line on the syringe, depending on whether they are treating a pediatric or an adult patient, and inject the medication instead of using a pre-filled EpiPen.
So especially relevant in the here and now because of rising drug costs without associated rise in manufacturing costs. So in other words, people are trying to make money off of patients who are incredibly ill.
One last thing I wanted to mention, because I've gotten a lot of questions about that, is the word consider in the protocols. If you look at the allergic reaction and anaphylactic protocol under paramedic, the last bullet point says that the paramedic and the critical care can consider the use of norepinephrine if needed after a fluid bolus is completed in order to maintain a mean arterial pressure of greater than 65 or systolic pressure of greater than 100. That term consider means that the critical care and paramedic may do that on standing order if they deem that it is necessary and beneficial to the patient. It does not mean that they need to necessarily call medical control. Now, if they would like to discuss this with medical control to determine the risks and the benefits of giving it, that certainly is indicated. But anything that is listed above that purple line of medical control considerations is essentially a standing order.
Fantastic clarification. Next up, we have chest trauma, as well as sucking chest wounds.
Chest trauma is something that we can encounter fairly frequently, and especially for those of us who work in a more urban environment, we may have patients fairly frequently who have penetrating trauma to the chest. For those of us who have a lot of experience with these patients, we may have seen a lot of chest wounds, but probably have seen very few or relatively few sucking chest wounds. And while it's important to remember that a patient that has a penetrating injury to the chest may develop a sucking chest wound, it doesn't mean that everybody who has a penetrating injury to the chest will suffer from a sucking chest wound. Now, what I mean by sucking chest wound is that when the patient takes a deep breath, or when they breathe in and create a negative interthoracic pressure, air preferentially crosses the defect in the chest wall as opposed to entering through the trachea. Now, in order for that to happen, the hole within the chest, if you will, has to be fairly large, and generally this is considered about 2/3 of the diameter of the trachea, which a lot of bullet wounds and other penetrating trauma is actually smaller than that. But that being said, one of the treatments for a sucking chest wound is to prevent that air from preferentially crossing across the chest wall and causing a tension pneumothorax. Now, the way that we typically treat it with BLS skills is to apply an occlusive dressing over the wound. We will oftentimes train providers to incorporate a flutter valve or tape the dressing on 3 sides, but this can be somewhat problematic, especially if there's a lot of blood and some difficulty in the adhering of the tape to the skin itself. To fix that problem, a lot of the providers have gone to placing a clear occlusive dressing over the wound, oftentimes one that is used for securing IV catheters. But the issue is that it may cause a tension pneumothorax to develop from a simple pneumothorax. So the important thing is, if dyspnea occurs, make sure that you release the dressing momentarily during exhalation to allow for the expelling of air from the interthoracic cavity to decrease that pressure.
I think it probably behooves us to review the indications for chest decompression in the setting of tension pneumothorax.
Yeah, I think that's a good one because a lot of people have questions about that. As I mentioned, that the indications for decompression with a needle is if a patient has a true tension pneumothorax. And while not all patients with a pneumothorax have a tension pneumothorax, it's worthwhile discussing what exactly we mean by that.
So if a tension pneumothorax, which is causing hemodynamic compromise, can be evidenced by potentially unilateral breath sounds, jugular venous distension, as well as tracheal deviation, the potential, because of the reduced preload, is our patient has hypotension and can potentially arrest. So we talk quite a bit about chest decompression, and we have increasing literature that we can't just use a simple angiocath. Number one, we need something that's at least greater than equal to 3.25 inches and a minimum of a 14-gauge catheter. We also had a paper released in the Annals of Emergency Medicine in this past year, which suggested that the common place where we initially strike for decompression, the second rib space, mid-clavicular line, may not be the most ideal place for decompression of the chest. That controversy aside, we have to remember that number one, we have to use a device that's appropriate for the job, so greater than equal to 3.25 inches and at least 14 gauge or greater. And then I think another point is that we can repeat the aspiration of air if our initial decompression was successful. In other words, we don't just have to leave that tube in there and pretend it doesn't exist. We can actually continue aspirating air out from that small aperture until the patient has a definitive chest tube.
I think that's an excellent point. And one thing that is extremely important, because this truly is a life-saving intervention, and if you do have a patient that is suffering from a tension pneumothorax, they may die if you do not perform this appropriately. And with the risk of not penetrating the chest cavity when you need to penetrate the chest cavity, it's important that we optimize our ability to do so by using the appropriate catheter within the scope of practice of what the protocols allow us to do. And I just wanted to underscore what you mentioned in regard to the indications for decompression. The reason why we don't want to decompress everybody is once we do that, we kind of obligate them to receive some sort of a chest tube or a pigtail catheter, which can impart a fair deal of morbidity to that individual. But if you do have a patient who is having hemodynamic compromise, and that is important and necessary to allow for pre-hospital chest decompression, is that they have to have hemodynamic compromise in addition to the signs and symptoms of a tension pneumothorax. Now, one other thing that we've had a lot of discussion about is the scope of practice of the critical care level. When we were putting together the protocols, there was a fair deal of variability across the state and amongst the different regions as far as what the critical care technician could do under standing order. Unfortunately, we don't really have any national-based guidelines because the critical care technician level is not part of the national EMT levels. So we had to try to develop a common protocol set that can be used across many different regions. Now, one thing I think that's important to say is that there isn't anything that is necessarily being taken away from the critical care level. Instead, there may be some instances in which some critical care technicians in certain regions may now have to call for medical control orders for things that may have previously been for them on standing order. But in order to bring everybody to the same level, it was important to try to find some common ground with the understanding that the critical care technician is still allowed to do many of the things that they have been able to do in the past, even though some may have to call for a medical control where in the past they may not have had to.
A final point regarding chest trauma and hemodynamic compromise is what to do with your patient that is in traumatic cardiac arrest. And while this remains controversial, a protocol that we've established under standing orders, which I think has the potential to save many lives, is the empiric use of bilateral chest decompressions to try and mitigate any pneumothorax, which admittedly is going to be very difficult to diagnose in the setting of traumatic arrest.
There are very few things that we can reverse, especially in the field of a patient who is in traumatic cardiac arrest. People who are in traumatic cardiac arrest generally do not fare well, especially in the pre-hospital environment. One of those very few things that we might be able to have an effect on is PEA from a tension pneumothorax. Now, in the protocol that outlines the declaration of obvious death, traumatic cardiac arrest is one of them, with the exception of those who have had traumatic cardiac arrest who currently have an organized cardiac rhythm, which essentially would be a PEA. Now, in this case, one of the potential causes of PEA is a tension pneumothorax. As you mentioned, it's very difficult to diagnose clinically in these settings. So empiric bilateral chest decompression for any patient who you are resuscitating in traumatic cardiac arrest is indicated.
Moving on to protocol 2-15, COPD and some nuances at the statewide level.
This protocol has to do with COPD exacerbation and bronchospasm. And within the protocol, the EMT basics may see that there's a little bit of a difference between this protocol and what has previously been written in the EMTB statewide protocol set. In this instance, the EMT basic is able to administer an albuterol nebulizer up to 3 doses if the symptoms persist on standing order. The statewide EMTB protocols are more restrictive. The EMT basic is permitted to utilize these protocols in the regions in which the collaborative protocols have been approved. So what that means is that even though the statewide EMT basic protocol limits the administration of albuterol to 1 dose on standing order, if the EMT basic is practicing in a region that has adopted these collaborative protocols, they may follow this and give up to 3 doses if symptoms persist.
Excellent distinction, and certainly can benefit many patients.
Other thing I wanted to mention in regard to this protocol are the combination treatments. There is the provision for the critical care and the paramedic to administer albuterol and ipratropium together. This can be mixed together with 2 separate drugs, or it can be given as a combination unit dose, such as a duoneb, which can be substituted for the albuterol and the ipratropium mixed together. Other thing is that in some of the protocols, depending upon the region, there was a limitation to just give one combination treatment. Now these protocols allow providers to administer 3 combination treatments mixed together.
Excellent. So next up we have protocol 2-19, heat emergencies.
Heat emergencies are very common, and if you are in the upstate New York region in the wintertime, heat emergencies may seem very far removed from your current experience. But notwithstanding, in regard to heat emergencies, one of the changes that some people may see is the administration of oral fluid to select people. Traditionally, we teach that patients who are being treated in the pre-hospital environment should not receive oral fluids. But for heat emergencies, that may actually have a significant beneficial effect. We want to make sure that people understand that this is for patients who are presenting with moist, pale, and normal to cool skin temperature. If the patient is not nauseated and able to drink water without assistance, they may drink water. Alternatively, if the patient is presenting with what we've previously called heat stroke, particularly patients presenting with hot, flushed, and dry skin, you do not want to administer oral fluids and instead keep the patient as cool as possible with cold packs and keep the patient's skin wet with moist sponges or towels.
I think those are great distinctions between heat exhaustion versus heat stroke. I also see this protocol being relevant in discussing patients or members of service, such as firefighters during firefighter rehab, which is firefighters who are engaged in battling a structural fire for a long period of time and may require some sort of treatment related to heat issues as well as generalized exhaustion issues.
Absolutely. Firefighters are very prone to heat emergencies, especially heat exhaustion in this case. Another patient population that is important to address in this protocol are those who are predisposed to water intoxication. Now, water intoxication occurs when patients ingest excessive water, which may cause potentially life-threatening electrolyte abnormalities. We see this a lot of times in long-distance runners who consume large amounts of water and present with collapse or confusion. The treatment for these patients are to cool the patients and to contact medical control before administering any fluid to a patient with suspected water intoxication. In the hospital, we would oftentimes treat these patients perhaps with either hypertonic saline or diuretics or fluid restrictions. But the issue is that if we administer parenteral fluids to these patients who are already water intoxicated, it can actually be life-threatening, even just the 2 liters that we may administer in the field environment prior to getting to the hospital.
In this patient presentation, it's very important to have objective data, a set of electrolytes to help guide your management. Hold off until you get to the emergency department.
Absolutely.
In regards to the use of oral medications, in hypoglycemia, I think, we've been emphasizing the BLS scope of practice for a patient that's not altered, has a known history of diabetes, and can potentially consider oral administration of glucose or another carbohydrate.
Yeah, so whenever you have a patient in this case who may have a low blood sugar but is able to swallow on command, you certainly may go ahead and administer oral glucose, and that's similar for adults and pediatric patients.
Now, in regards to a nuance between peds and adults, oftentimes there are many agencies that carry both D10 as well as D50. Now, that may not always be the most sophisticated approach to pre-hospital hypoglycemia.
Yeah, so what we found is that D10 actually works remarkably swiftly, and that there is actually a similar onset of action and similar administration time for patients who get a dose of D10 for hypoglycemia compared with those who receive a dose of D50. Now, when we administer the 25 grams of dextrose, it can be a volume of which depends upon the concentration. If we give the D50, we can administer that in a smaller volume than the D10, which essentially is 250 cc's. When we have a patient that requires parenteral glucose, administering 250 cc's of D10 versus the 50 cc's of D50, we find that the patients respond just as quickly to the D10, and it really takes just about as much time to administer the D10. We have switched from administering D50 and carrying D50 on the ambulance to carrying D10 because of this. Now we only need to carry one concentration, and the other benefit is that there is less risk to the patient if that fluid extravasates. With a D50 that's very highly concentrated and can be detrimental to the soft tissue if the IV blows, and if the D50 comes in contact with the subcutaneous tissue, it can actually cause necrosis in some cases. In addition, the osmotic effects of administering D10 are much better because the concentration is more physiologic and less concentrated than essentially the maple syrup that we've been traditionally injecting into people's veins with the D50.
Excellent point. And just one final note is for patients who don't have IV access or are difficult to obtain IV access, we can administer glucagon via an intramuscular route. And we should also remember that glucagon can also be administered intranasally. So just something to keep in mind. Next up, we have Protocol 2-26, musculoskeletal trauma and pelvic fracture management.
So pelvic fractures are something that we oftentimes overlook in our trauma assessment or our trauma interventions. We do know that patients who have unstable pelvic fractures, it can be very difficult to reliably identify those patients based on physical examination. And the recommendations at this point are, instead of checking for pelvic girdle instability by rocking the pelvis or something similar, that we simply treat a patient for presumed unstable pelvic fracture based upon their mechanism of injury and index of suspicion. So for these patients who have undergone a significant trauma, the recommendation is to simply bind their pelvis, preferably with a commercial device. These devices can more reliably align the pelvis than the traditional sheet maneuver, where you would bind the pelvis by essentially tying a sheet around the pelvic girdle. Regardless of which commercial device you use, a pelvic binder should be considered anytime you have a patient with significant trauma for whom you think that an unstable pelvic fracture is a possibility. We really don't want to be rocking the pelvis because the concern there is that we can potentially dislodge any clots that may have formed and cause additional bleeding to occur internally.
Piggybacking on the idea of trauma, which is inherently painful, Protocol 2-32 discusses general pain management and approximate weight-based dosing, where the provider is now allowed to round the dose of medication administered.
Whenever we give pain medication, we obviously want to provide the appropriate dose for the appropriate patient. Now, it's very convenient to have a standard single dose for adult patients, but we know that patients of different weights require different doses of pain management in order to become effective. Oftentimes happens is that we end up providing pain management that is suboptimal for that patient. When we were trying to balance the ease of administration of a single dose versus the optimization of effective medication administration and dosing, we came up with the idea to utilize a weight-based dosing with the ability to round the dose to a particular amount. So, for example, in the pain management protocol on standing order, the provider may choose to give morphine, and the morphine dose is 0.05 milligrams per kilogram IV or 0.1 milligrams per kilogram IM. The morphine may be repeated after 5 minutes to a maximum dose of 10 milligrams on standing order. But if you turn your attention to the key points and considerations for ease of administration and if clinically appropriate, you can consider approximating the dose of pain management based upon the nearest 5 milligrams for morphine. Now, for fentanyl, we have a similar provision in the protocols in that the provider may approximate the dose of fentanyl to the nearest 50 micrograms. So this prevents the provider from having to draw up or calculate obscure dosages which may predispose to error. While we maintain the ability to dose the medication based on weight, we also have the ability to approximate so that we can facilitate administration and decrease potential errors.
Now, in discussing morphine versus fentanyl, I think it's a great teaching point to delineate that morphine is an older opiate, whereas fentanyl is a newer synthetic opiate. As such, many people think that they have an allergy to morphine, and we should differentiate between a histamine reaction, which is quite common with morphine administration, and patients may feel nauseous or feel a wave of heat, things along those lines, versus a true allergy where they develop urticaria or may have signs and symptoms of anaphylaxis.
Right. Morphine, one of the normal effects of morphine is the histamine degranulation from mast cells. And when a patient has histamine degranulation, that essentially produces what we commonly see as an allergic reaction. And morphine can normally produce a localized histamine reaction, which may actually even manifest as hives immediately surrounding the IV site. If it's localized like that, it's not considered a sign of a true allergy. But if a patient does develop extensive involvement of urticaria or hives or other signs of allergic reaction, it should be treated as an allergic reaction.
Excellent. Now, in regards to fentanyl, one of the very rare but reported side effects is rigid chest syndrome, and that has to do with the rapidity or how quickly the medication is administered.
Right, so to avoid that, we want to make sure that whenever we push fentanyl IV, it's pushed slowly. Granted, rigid chest syndrome is rare, but it can be very difficult to adequately ventilate a patient who is suffering from this side effect.
Now, transitioning a little bit to also discuss a nuance of pain in regards to vascular access. We oftentimes use intraosseous lines for patients who are unconscious and don't consider that the administration of medications or fluid through these lines may be inherently painful. However, these are becoming increasingly common to use in patients who are conscious, and we should consider the administration of lidocaine at a slower infusion rate so that it can dwell in the marrow space to allow the maximum effective use of the intraosseous line.
Yes, it's important that when we consider giving a lidocaine that we don't do it as a rapid bolus, because if we do that, then it is simply going to go into the circulation and not dwell within the marrow space where it would have its beneficial effect. The manufacturer will oftentimes describe a method for administration. And for the EZ-IO, which is one of the more common devices that's used in the pre-hospital environment, the recommendation is to slowly infuse this over 120 seconds, which is 2 minutes, and to allow it to dwell in the marrow space for a significant amount of time so that it can do what it is intended to do.
And along those lines, for challenges in access and obtaining access, I think it's also important to remember, especially in children, that we have various routes of administration available, including intranasal and if necessary, including PR or per rectum.
Another thing that we have oftentimes heard is that if a patient is going to be, quote, ALS'd, unquote, that they need to have every ALS intervention administered, including IV and a cardiac monitor, but that's not necessarily the case. We should provide the interventions that the patient requires. And in children especially, this may mean not necessarily jumping right to an IV. For pain management in children, intranasal fentanyl is an excellent option that prevents the unnecessary IV stick and something that is oftentimes used for pain management after an acute fracture.
Excellent point. And regarding fractures, Protocol 4-9, some nuances to trauma criteria.
Yeah, the one thing that I wanted to mention there are the destinations, the patient destinations. In the past, I've heard a lot of questions in regard to whether or not a patient should bypass a level 2 trauma center in favor of a level 1 trauma center. Now, a lot of this has to do with the resources available in that particular trauma system. But in general, there are some guidelines that are put out by the CDC that can help you to make that determination. In this protocol, there are various categories, 1 through 4. If the patient meets the criteria listed in Category 1 or Category 2, they should be transported to the highest level trauma center in your system. Now, this may be somewhat dependent upon how far away your highest level trauma center is and what the general patient population that your various trauma centers are used to managing. So this may need to be done in consultation with medical control if there is a question, but this is somewhat dependent upon your particular region and the resources available.
Fantastic. And with that, we wrap up podcast number 2 on the New York State Collaborative Protocols Historic Update. Please be sure to check out the additional training resources which will be available for free to New York State providers. Chris, for folks who did not listen to podcast number 1, where can they learn more about the New York State Collaborative Protocols?
Well, the collaborative protocols are going to be available as an app on both the iOS and the Android platform, free of charge. So you can look for New York State EMS Collaborative Protocols, and that can be downloaded for free.
And with that, this is a humble attempt by a group of clinical educators to advance the pre-hospital care within our state. And we certainly realize there are a lot of folks out there who may be listening that are also doing incredible things in regards to pre-hospital protocols and optimizing the evidence to deliver the best care possible to our patients. So with that, we would love your feedback. We would love your insight. Please do not hesitate to get in touch and let us know what you think about the protocols and how we can improve and continue to optimize the care of our patients.
And I want to personally thank everybody for their time and wish you guys all the best in your endeavor, which is a very noble profession and one that I very deeply care about. So thank you.
With that, this is Faizan Arshad and Chris Fullagar wishing everyone a safe tour.